breast cancer survivor. Oh my God, this is the first time I say it.
Good morning. We're gathered here today to discuss the management of the HER2-positive breast cancer. Gathered in the table with us are three other experts in the area. I'm Dr. Silva, a surgical oncologist at the Fred and Pamela Buffett Cancer Center at the Nebraska Medical Center in Nebraska, and I will have my colleagues introduce themselves.
I'm Lisa Carey. I'm the Chief of Hematology Oncology at the University of North Carolina Lineberger Comprehensive Cancer Center.
I'm Wadad Hanna. I'm a breast pathologist at Sunnybrook Health Science Center, Professor of Pathology at University of Toronto, Canada.
I'm Julia White. I'm the Director of Breast Radiation Oncology at the Stephanie Spielman Comprehensive Breast Center at the Ohio State University Comprehensive Cancer Center.
As part of our activity today, we are going to look at three cases that represent the management potential opportunities for patients with HER2-positive breast cancer. The first case we'll present to the group is a 30-year-old African-American school teacher who unfortunately presented with a palpable left breast mass and unfortunately also had palpable left axillary disease. She underwent a core biopsy of this lesion, and the immunohistochemical studies showed that the lesion was HER2 positive. In most hospitals nowadays, there is a concern about the reliability of these tests when performed on the outside, and for that reason, we always ask our pathologists to review these slides before we make any treatment decisions. Dr. Hanna, what do you think?
I think I would like also to state that testing on core biopsies as a standard of care should be really adopted, and the new ASCO CAP guidelines support that. Testing for biomarkers in general should be done in standardized lab with participation in quality assurance programs. So if you feel comfortable that the testing is done somewhere where this kind of qualification is fine, but if you are not, then I would support the fact that you review or retest at a center where there is larger volume expert pathologist interpreting the data, because you don't want false positive or false negative. But we're comfortable that testing on the core biopsy is accepted and correlate very well with the surgical excision.
As a pathologist, do you have any recommendations for our colleagues in diagnostic radiology regarding the number of cores you would prefer to obtain to be able to rely on your specimen for diagnosis?
We usually like at least 3 or 4 cores for diagnostic pathology. And if there is less than 2 millimeter invasive carcinoma in the core, we feel that this is not adequate and we might go back. The other thing is that if there is, as in this case, a palpable node, we recommend that they can have a fine needle aspiration sample to give us an idea that she's positive or negative. But we don't necessarily use the FNA for testing for the biomarkers. However, it could be done if this is the only sample that you have.
Dr. Carey, in this setting, when patients come to you, do you routinely examine the axilla, whether they're palpable or not, with ultrasonography as an attempt to stage the axilla preoperatively?
Yes, we do. We routinely use ultrasound, which I think is a key part of getting, really as detailed a clinical staging as you can if you're considering neoadjuvant therapy.
And in a multidisciplinary center, Dr. White, where you may be involved at the outset in the patient care, in a patient like this with palpable axillary disease, would you look for any other means to establish the absence of disease, say, in the superclass or elsewhere?
So I think this patient so far is a relatively small tumor, just over the clinical edge of a T1 into a T2. Certainly in a patient who's more locally advanced, we want to make sure, as a radiation oncologist, we know in the region where all suspicious disease is, so that we can really be able to comprehensively address that. If we don't know about it, we can't do our best job of using radiation after she's done with both her chemotherapy and surgery. So it's important for a patient that you think is more, I would say, the clinical stage 2Bs and above, if you have suspicion that she might have nodes other than the ones you can feel, to do a CT of the thorax with careful attention to the supraclavicular and axillary regions and internal mammary.
Would the CT be sufficient, or would you require a PET? as some have?
So, I think we have to be careful here because we know that most patients who are asymptomatic in early stage 2Bs, they're not going to have findings in distant metastases. And I think that we encourage not the overuse of those studies. This is a specific use so that we can adequately address her local regional disease because we hope for her she has a great pathologic response, right? So, but then we need some sort of roadmap, if you will, where her original disease was. So I'm not doing this to kind of rule out her metastatic sense. I think we get a sense of that clinically if she's asymptomatic and follow NCCN concordant guidelines on that staging. This is really to get a good sense if you think that there might be disease outside of what you can feel in her axilla or her breast, so that we do an appropriate job with her radiotherapy afterwards.
I think you're on the money about that. Obviously, the asymptomatic patient in this setting would harbor about a 1.2% chance of having metastatic disease. In stage 1, it's 0.2%, and we know that the American Society of Clinical Oncology has recommended that we do not spend unnecessary resources in such tests, but this is a focused exam you're requesting because it may affect your radiation reports, for example.
It is. It's analogous to the statement that we want to just make sure we understand really well where her disease is prior to as we start off, because I think it affects all of our decisions.
So in this setting, even though it happens to be a small lesion, the patient is 30 years old. Dr. Carey, would that be an automatic indication for a potential BRCA testing?
Yes.
So this patient, by age alone, even though she has a very small tumor, would then require some additional, shall we say, counseling, and that may take some time. Now, in our institution, even though we no longer rely on Myriad, that used to take much longer, the fastest turnaround for our own laboratories genetic testing is about 2.5 weeks. Is that concordant with your institutions?
Yeah, ours is 2 to 3 weeks.
Yes, right.
And would that delay in any way affect your decision to proceed with pre-op chemo or not to use pre-op chemo in a setting like this?
Depends on the patient. I mean, to be honest, some of these patients already are not interested in breast conservation, at which point there really isn't anything to be gained by waiting for the BRCA testing to come back, unless they're going to make a decision about contralateral disease at the same time. So it kind of depends a little bit on frankly, the discussion between the patient and the surgeon about what a 30-year-old who has already one breast cancer and what they want to do. If they are interested in breast conservation, or if it will inform decision making about the contralateral breast at the same time, then I think you can either wait. And to be honest, I think we do need to send the message to patients that it's seldom, a 2 to 3 week difference is seldom a clinically meaningful. On the other hand, here we have a T2, at least N1 tumor. We already know that we're going to be giving systemic therapy, so there's little to be lost by starting with neoadjuvant chemotherapy, and it may be certainly reassuring to the patient.
I mean, I think that's our posture in that we know that nationally the minority of women in this setting would be referred for genetic counseling prior to undergoing surgical management. Most studies show maybe a third of all women ever meet with a genetic counselor preoperatively, although, as you all know, the Angelina Jolie story seems to have added some fire to that, or fuel to the fire, and maybe more women, either appropriately or inappropriately, are seeking genetic counseling. So in this case, as you pointed out, she does have nodal disease. Would you then consider the neoadjuvant setting as an appropriate option?
I think it's perfectly appropriate. To be clear, somebody with palpable nodes, we would do an aspiration and confirm the involvement of the nodes, because I think it is very, particularly for the radiation therapists down the road, helps them make decisions. So assuming that the pathology confirms the nodal involvement, I think it's totally appropriate.
In our practice, we do find needles if the patient is in clinic and we happen to be able to do it right on the spot, and it gets read literally on the spot. But in many cases, they need ultrasound guidance, in which case the radiologists prefer the core biopsy. I'm not sure why they're more comfortable using the core device than a fine needle, mostly because the cytopathologists that we have are very good at doing the needle aspiration themselves. But if radiologists are involved, they'll do a core and they'll put a clip in the node. And historically, we've tried to visualize the clip intraoperatively when we do the sentinel node biopsy. Unfortunately, as you know, sometimes that clip does not happen to mark the exact sentinel node that we find at the time of surgery. But in this setting, then you would expect the patient to start the course of neoadjuvant. And at what point in time do you decide the patient is ready for surgery?
Well, so typically, in a patient like this who's very young and healthy with nodal involvement in HER2-positive breast cancer, we typically would give a third-generation regimen with trastuzumab added. And so typically, unless there's a reason to do otherwise, we would give all of the chemotherapy up front.
Are there any reasons for which you would never give it all up front?
Sometimes if we are uncertain that we want to give an anthracycline, for example, in several of the trials that looked at neoadjuvant administration of chemotherapy plus HER2 targeting, they gave a taxane HER2 targeted regimen, and then the patient went to surgery, and then there was optional use of an anthracycline out back. And we don't know that that's the best way to do it, but there is some precedent for doing it if there's uncertainty, for example, a patient with cardiac risk factors where you maybe want to try and be a little more tailored. In general, I try and give the chemotherapy and make the decisions up front, but there are some circumstances where you can decide otherwise.
And following the use of the neoadjuvant, do you restage the patient in any way prior to having them undergo surgery?
Oh, breast imaging. Mm-hmm.
Breast imaging. MRI or mammogram?
So I think it really depends on up front. If, let's say, for instance, a patient has desired mastectomy up front, and she's very committed to that. I don't think you necessarily, if you're going to remove the breast, you want to know about response, obviously, but you'll get that pathologically. I think if she's interested in breast conservation, I think there is a general consensus that MRI is helpful for assessing response, but not necessarily in all cases, depending on how, the density of the breast, the shape, whether it's a unifocal or a more dispersed. You do want to know, I think it helps the surgeon to know that you can get from MRI, has it shrunk nicely as a unifocal lesion, or is it shrinking more with more a multifocal where it's just spreading small spots all around? I think that's more concerning as you go in. So I do think there's aid, and if you're thinking about breast conservation, and adding an MRI actually up front, I think, and then after your chemotherapy prior to surgery, if there's concern about her suitability for breast conservation.
I think the small study that Dr. Morrow remarkably was one of the authors on, despite all her previous concerns about the reliance on MRIs, does suggest that it may be useful in the setting of neoadjuvant therapy to measure the response to the therapy after the completion of treatment. So I think in summary, this case does suggest that a young individual with a HER2-positive breast cancer who is not a gene carrier, or even if they were a gene carrier, would still be considered a candidate for adjuvant therapy. In the gene carrier setting, we tend to favor the use of pre-op chemo because many of these patients may opt for nipple skin sparing mastectomies, and we really would like to eliminate any potential likelihood of margin positive disease when we perform a nipple skin sparing mastectomy, and thus we encourage them to continue to have the pre-op chemo in that setting.
It's important to biopsy at the base of the nipple if you do skin sparing, so that there is, for sure, at the frozen suction time to ensure that the interior and base of the nipple is negative.
I think we've gone back and forth with that. There's some wonderful data looking at coronal sections of the nipple, showing that the absence of tumor at the base of the nipple may render the rest of the nipple absent of any potential disease. The problem is that we've done a couple of cases where we got the frozen section positive and the final came back negative. And so what we do now is basically wait and give you the entire specimen. And if I have to go back and remove the nipple, we do it with the certainty that you're comfortable with the proposition that there was a positive margin, rather than do it intraoperatively only to find out after the fact that the frozen section may have been less than reliable. And so I think that's sort of the practice sweep on the country where we just give you the whole thing and you tell us, and then we can always go back and tell the patient beforehand that this may be a problem. But that setting is exactly the one for which we prefer to have the pre-op chemo. Dr. White, any other commentary on this case?
No, I think it's important that all the disciplines meet this patient very early in her course so that she's prepared for what to expect down the road in terms of, she's a young person, she may have children, she may have, work things, obligations, so we want her to know that she's going to have several months of chemotherapy, her surgery, and then a daily commitment to radiotherapy if she had positive nodes. So I think it's important that we all meet her and so she knows what to anticipate.
And what do you radiate in somebody with axillary involvement up front?
So she's actually, I think it's a great question, because I think it's hard for patients to understand if we're doing such a good job and she's responding, why would she need the radiotherapy? And I think, in fact, there's clinical trials, because there's a lot of debate about this. I know in our own practice, this is one of our common debates in our multidisciplinary tumor board. So we would encourage enrollment in clinical trials. But we know that in particularly a young woman who has positive lymph nodes, if she had had surgery up front, there's just a really substantial evidence that you improve by reducing her local regional recurrence by radiating where her breast used to be after mastectomy, and then the lymph nodes, the retained lymph nodes, if you think of it, not the ones that come out, but what's retained. So the upper level of the axilla, supraclavicular regions, and the internal mammary regions. For subclinical disease, you're trying to change the course of her breast cancer. But she might need that course changed, as she would in the adjuvant setting after surgery, if she responds to chemo. Then that's what we don't know, and that's the great debate.
And that's what the trials are about.
That's what the trials are about.
And that's true, exactly. The question is how much more benefit can we add to the patient whose axilla has been rendered free of tumor by using radiation therapy, and all of us are enrolling patients in the 2 RTOG trials that are up in that particular setting. Thank you to our panelists, and we'll adjourn for our next case.